Yeah, I'm good.
Okay. So I'll go to OB first. So tell me what you guys like want to go over, like topic wise, because there are a lot of pages. I just want to like whatever you guys think you're struggling most with.
Can you go over, so where she put tocolytic therapy, there
Mm-hmm.
was two questions. So one is, in what gestational scenario is tocolytic therapy indicated or contraindicated? And then the third question, it's kind of similar, but it doesn't say gestational scenario. It just says, when would the administration of toco be appropriate, and in which case would it be on contraindicated?
Okay. So mainly with that, you just have to remember like tocolytics, like whenever you see like lytic at the end of anything, it means like you want to stop. So here, like we want to stop contractions. So you only want to stop contractions if we completely do not want her to have the baby right now. So it's appropriate for you to want to stop contractions between 24 and 34 weeks because that is really early for a baby to be born. The lungs are not mature yet. Those alveoli are not mature. There's not enough surfactant around those alveoli as well. So we really do not want a preterm baby, especially that 24 to 34 week period, just because the lungs really are not fully mature yet. So we just want to delay birth and then administer corticosteroids like terbutaline. And then contraindicated to not administer a tocolytic would be if there's an intrauterine infection, because you do want to get that baby out fast just to prevent any other like complications. And then fetal distress, you do need to get that baby out. Um, and then severe preeclampsia or eclampsia, and then advanced labor or fetal death. When you don't want to use a tocolytic, it's because you need to get that baby out sooner than later. Does that make sense? These are sort of similar questions. This one is sort of similar to this one.
Yeah, I felt like they were similar, but I don't know. For some reason, I felt like she was like either gonna trip us up or like.
Yeah, they're very phrased like differently, but basically asking the same thing. Yeah, indicated, contraindicated scenarios. Yeah, I feel like they're just the same thing, honestly. I don't know how she would make that different. Do you guys feel okay with magnesium sulfate?
I do.
Okay. I'll just go over it briefly. Magnesium sulfate has a lot of indications, so we can administer that. It's a muscle relaxant, so it can stop contractions. And then we also use that to prevent seizures. So a lot of the time we give it with preeclampsia, so it's always important. Preeclampsia is pretty common, so it's that pregnancy-induced hypertension. It is really common for patients to get preeclampsia, and we never want that preeclampsia to be advancing into eclampsia, so that high blood pressure, now it's seizures. Um, so
And a
it's,
neuroprotectant for the baby.
yes, you're right. And then assessments prior to and during administration. So always do your vital signs, especially in this case, if you're giving it because of the high blood pressure. Of course, you're going to want to do your vital signs, and especially respiratory rate, because magnesium sulfate can cause respiratory depression if it's at that toxicity level. And then deep tending reflexes. This is key. I'm just going to put this in red. This is always a question they like to ask because this is your key sign. Like if the deep tendon reflexes are less than 2, like say they're like 1 plus, that's a sign of magnesium toxicity, and you're going to want to stop it and then administer that antidote, which is calcium gluconate. Urine output should be greater than or equal to 30 milliliters an hour. If it's less than that, then that's telling me that those kidneys are not being perfused correctly, which that high blood pressure can do. And then fetal heart rate and uterine activity, ongoing assessments. You always want to monitor your respiratory stats because that's telling me if that magnesium is becoming too toxic, but also we are also looking at that the blood levels of that magnesium in the blood. So that's a good indicator as well. Deep tendon reflexes, that's our key sign for magnesium sulfate. During boot camp, even Dr. Beard said you always have to look at deep tendon reflexes. That's going to be your key indicator for toxicity. Monitor urine output. We want to make sure those kidneys are being perfused and there's no toxicity, and then monitor for signs of magnesium toxicity. And that's mainly going to be like your deep tendon reflexes, the respiratory status decreasing, and maybe even EKG changes where that patient's going into cardiac arrest or respiratory arrest. And then, yes, calcium gluconate is your antidote. So we need to have that readily available. If toxicity occurs, earlier signs, loss of deep tendon reflexes, respiratory depression, lethargy, or decreased level of consciousness. So the main thing you want to know is, magnesium sulfate helps with a lot of different things, but always remember it is a muscle relaxant. So if it works too well and it's relaxing this patient way too well, then things can start to decrease a lot, like the deep tendon reflexes and the respiratory rate as well, and then the level of consciousness too. So that's something to monitor for. All right. Any other topics you guys are like really struggling with that you want me to go over with OB, or I'll just like go in order? Oh, everything? Okay. So postpartum hemorrhage, what should the nurse assess first in a client with hypotension during the immediate postpartum stage? The patient's having hypotension and tachycardia at the same time, that's a sign to me that this patient is experiencing hypovolemia. So right off the bat, if I'm seeing those two things, the hypotension and the tachycardia, I'm going to be thinking she is bleeding from somewhere and hemorrhaging. So I'm going to want to identify the cause really fast. Women can hemorrhage for lots of different reasons. It could be because of uterine atony, or it could be because of a hematoma, or it could be because of during a C-section, maybe that surgeon nicked an artery. Now she's having internal bleeding. So there's a lot of different ways, or even like a retained placenta. So I need to identify the source. Is it because of uterine atony, which is going to be the most commonly tested one that they test on because it's the most common cause of postpartum hemorrhage. And that's the one where the uterus is just not contracting, and we need the uterus to keep contracting after delivering, just so the woman doesn't hemorrhage. So you go into the room where you're gonna assess the uterine fundus. Yeah, so atony, the uterus isn't contracting after birth, so it's soft and boggy. We need that uterus firm, midline, and at the level of the umbilicus after delivery. All right, and then, so right off the bat, I'm going to assess the uterus because I want to see if this is due to uterine atony. And then if it's soft and boggy, I know it's uterine atony, and I'm going to right off the bat start doing a fundal massage. And then you're also going to want to assess the peripad, check for vaginal bleeding. Is this woman saturating a pad quickly? She should never be saturating a pad in less than 15 minutes. It's only okay if a woman is, having heavy bleeding at the peripad if she's 1 hour post-op. That's completely normal because she just gave birth. But if it's happening like 5 hours later and she's saturating pads, she's going through the peripads really fast, that's not normal. She should never be bleeding that heavy. Only within the first hour, it's okay if there's like large amounts, but not really after that first hour. Then we're going to start to be concerned. Check level of consciousness. Level of consciousness is always your indicator if something's wrong. Level of consciousness is always there's always something. It's a cause of something bigger always if someone has a decreased level of consciousness. Bladder status, is the bladder full? Like we said, like a full bladder can distend or displace the uterus to the left or right, and then that can also cause you postpartum hemorrhage. So there's lots of different reasons for postpartum hemorrhage. So we want to identify the cause. If it's uterine atony, I'm going to massage the fundus. If a hematoma or rupture, they're going to have to contact the physician, and they're probably going to have to do like a surgery or something. And then if it's internal bleeding because of that C-section, then again, surgery. All right, uterine findings that may indicate atony. Like we all talked about, it's soft and bodgy and it's mushy. And remember, we're looking at the fundus, and the fundus is the top of the uterus. That's all it is. You're just feeling that for the top of the uterus, and it should always be at the level of the umbilicus after birth. After C-section or vaginal birth, that fundus should be at the umbilicus. And then it's decreasing 1 centimeter each day. And that's how I know that the uterus is, going down like it should be. A boggy uterus means the uterus is not contracting, so there's no pressure on the blood vessels at that placental site, leading to continued bleeding. So remember, with uterine atony, so women bleed after they give birth, and they're bleeding from the site of where that placenta was, because the placenta was attached to the uterine wall. So if now that placenta is not there, now that woman is bleeding from that site. We need contractions to happen because it's going to constrict those areas and decrease bleeding. So that's why we administer oxytocin right after she gives birth to stimulate those contractions. But if uterine atony is happening, there's no contractions happening. So that's why we give oxytocin. It constricts those vessels. It prevents that bleeding. Of course, there's still going to be some bleeding, but we don't want it to be to the point where there's hemorrhaging happening now. But that's what that helps with. Key findings include soft boggy uterus on palpation, accompanied by excessive vaginal bleeding. So you go in, you feel that the fundus is soft and boggy, and then you also see that there's bright red blood a lot on her peripad or coming from the vagina, and you know it's uterine atony. This is the most common testedly one. How should the nurse respond to a displaced or boggy uterus? Displaced, like I said, a full bladder can displace the uterus to the right or left, and that can cause postpartum hemorrhage. So women after an epidural, they can't feel the sensation to void. So if you're like on a mother baby unit, you need to pay attention to how much urine she's retaining. That's why we have bladder scans to check how much urine is in the bladder. And usually I believe if it's greater than 300, they're gonna straight cath the woman. So you just, and also like if she has a sensation but she's having that post void residual, then you're just gonna help assist her. May have to be cathed as well. A full bladder can cause the uterus to deviate. Yes, all I said. And then a body uterus, you feel it, and then you check the vagina, and you see that she's also bleeding from there. You're gonna massage that fundus because you know it's uterine atony, and then you're gonna prepare for oxytocin to be administered because we need those contractions to happen. A fundal massage, what it's doing is basically you're massaging the top of the uterus, the fundus, and you're basically reminding that uterus to contract and contract and contract. You're just reminding it. And then the oxytocin does the contraction. So those both help. All right. Any questions? Okay.
I'm good.
All right. Uterine fundus may indicate atony. All right, I want to list tocolytics, infections in labor. What signs suggest chorioamnionitis in a laboring patient with ruptured membranes? So right off the bat, if her ruptures have if her membranes have ruptured, that's the amniotic fluid that ruptured. And usually if it has a color to it, or if it's foul smelling, right off the bat, I'm gonna be thinking she probably has chorioamnionitis. And then it's often, remember, it's an infection. And whenever someone has an infection, they usually have a fever. And then tachycardia as well, fetal tachycardia as well, uterine tenderness. And then, of course, you're going to see an elevated white blood cell count. Those are all indications of infection in labor. Immediate nursing assessments for a febrile patient. Vital signs, of course. Fetal heart rate pattern. How's the baby's fetal heart rate? Is it decreasing? Is it at the right level? Is the baby having, variable decelerations, uteroplacental? Like, we want to see what's up with the baby. Characteristics of the amniotic fluid. What color is it? Usually with chorioamnionitis, it's going to be like a greenish color because it is an infection. Signs of labor progression, notify the provider, obtain cultures, antibiotics as it is an infection.
If
Uh,
their membrane's ruptured and you don't have a group B on file, would you still give them antibiotics?
um, I'm honestly not too sure. I believe the antibiotics is after the baby is born. Are you talking about the GBS?
Yeah, group B strep.
Honestly, with the GBS, I feel like that's just when they like swab the woman and see if she's positive or negative, and if she's positive, antibiotics. Certain antibiotics are fine to give when she's in labor. It just depends on the antibiotic, but that should be fine because they do give antibiotics during labor. Was that your question? I
Yeah,
don't know if
just
I answered it.
yeah, there was a question on ATM. I'm gonna see if I can find it and send it to you. But it
Yeah.
was saying something about how like they didn't have GBS on file.
Um,
So it's like, would you still administer the antibiotic or not? And I feel like you would, just in case, to err on the side of caution. I just don't remember what I put and what the question was, but I'll send it.
yeah. GBS is caused by natural bacteria within our body. It's just in some women it can be in the vaginal canal, so that's why we'll give that antibiotic. But here we're just going to talk about chorioamnionitis, just what we're going to look for in our assessments. But GBS isn't like a common like infection. It's just a thing we would just manage with antibiotics. Preeclampsia and severe features. Let me see how long this is. I just want to look at the other topics. Okay. All right. And if anyone has any questions, you could just speak it out loud. I can't really see the chat. It doesn't like notify me. So preeclampsia is your pregnancy induced high blood pressure. So we have our early signs and symptoms and then worsening severe features. The main thing with the severe features, we want to remember that the severe features now, it's affecting the whole entire body. It's affecting other organs. That's the main thing we want to think about. So with preeclampsia, as far as severe features, includes worsening hypertension. So with early preeclampsia, and preeclampsia is not that serious, you're just going to have a high blood pressure and just not symptoms on other organs. Like if you have a severe headache, that's telling me that there's vasoconstriction and there's not enough like good blood supply happening to the brain, visual disturbances as well. This is a really big one if you're experiencing epigastric or right upper quadrant pain. That's a key sign and symptom that's worsening. Decrease urine output. You want to think the whole thing with blood pressure, especially if it's high, it's causing a lot of vasoconstriction. And if a patient is experiencing like say their blood pressure is like 200 over 100, that's very high. That's something there's a lot of vasoconstriction occurring. So if you have vasoconstriction within the artery going to the kidneys to help supply it, that means the kidneys are not being perfused properly. And if not being perfused properly, they can't do their job properly. So that's why you see that decrease urine output, and you just see a lot of signs of multi-system organ involvement, or you now have epigastric pain and headaches with potential development of HELLP syndrome. This is the biggest complication. Definitely remember it. It's really important because this is the worst case scenario if preeclampsia goes undetected. There was a story of a mom in I think Long Island. She gave birth and she had the preeclampsia throughout her whole entire pregnancy. And she, like right after birth, she got to meet her baby and everything, but then she was experiencing epigastric pain and her blood pressure was high. But the doctor kept saying that it was just GERD, but it obviously wasn't. And the nurses weren't advocating for her or anything. And it then progressed into HELLP syndrome, where she was having that hemolysis, which where the blood cells are being destroyed, and then elevated liver enzymes, where now the liver is being impacted, which we never want to happen, and then low platelets, where bleeding's occurring. So this all added for her to have a hemorrhagic stroke, where blood vessels ruptured in her brain. So that's the worst case scenario. So it's always important if you want to be an L&D nurse or even postpartum, because preeclampsia is high blood pressure induced in pregnancy, but it does take 2 to 3 days for that blood pressure to go back to normal. It's not like you're going to give birth and your blood pressure goes back to normal. It's going to take a couple of days for that preeclampsia to go away. So that's why even on like a mother baby unit, you have to pay attention to these signs and symptoms still, because the doctor tried to defend himself saying, oh, she gave birth, so I didn't think she was still having preeclampsia. But the preeclampsia persists even like 2 to 3 days after giving birth. So it's still important to manage that high blood pressure even after giving birth. Clinical findings, yeah, those down there. Yeah, that's the main thing here. Deep tending reflexes and blood pressure, because usually with preeclampsia, they have high DTRs. So, and then when you put them on magnesium sulfate, then those deep tending reflexes can disappear. So that's why it's always important to monitor for, and then especially when they're on that medication, we want to make sure that it doesn't depress too much. All right. Yeah, this is just repeating itself. All right. Preeclampsia, blood pressure greater than 140/90, and then it's accompanied by proteinuria. So that's the main things: protein in the urine, and then high blood pressure. And if it progresses into being severe, then it affects multiple organs. All right. Our goal here is to prevent preeclampsia into progressing into eclampsia, which is the one with seizures. So that's our biggest goal, is to prevent that, because with seizures, patients cannot protect their own airway, so there's always that risk, and also that permanent neurological damage as well. Yeah. So that's the main thing, and you're going to experiencing protein in the urine, raising blood pressure, and edema. So the edema happens because if someone's having protein, they're peeing out so much protein, and then they're like peeing all this protein out. There's not going to be enough protein in the blood now, and we call that hypoalbuminemia. So that means that there's low protein within the blood. And whenever that happens, that not enough protein within the blood, not enough albumin. Albumin is a protein, by the way. Edema happens. So that explains the edema. So you're, of course, going to have raising blood pressure. The patient's peeing out so much protein, so there's not enough protein in the blood. So that's why edema occurs. Manifestations: epigastric pain. Always remember epigastric pain, hypertension, proteinuria. The way I remembered it is I went through wait, let me just finish going through it. Okay, headache, visual disturbances if there's not enough perfusion to the brain, decreased urine output, especially if those kidneys are not being perfused right, increased sodium, BUN, uric acid, and creatinine, because again, the kidneys are not working properly to filter out everything. Whenever you see these guys increased, it's because the kidneys are not being properly right. Whenever I see these elevated, it tells me that there's something wrong with the kidneys. Specific edema and pulmonary edema. The way I memorize it, I just go through body system. So I think head to toe, and I'm like, head to toe, I'm thinking of each manifestation. So brain, you want to think, what could this patient experience if there's so much vasoconstriction happening within that cerebral artery? Headaches, visual disturbances, things like that. Deep tending reflexes are out of range. They're usually very increased. Lungs, so work your way down when you're thinking about all the manifestations. So lungs, so that vasoconstriction within the arteries of the lungs, difficulty breathing, chest pain, and then liver, any abdominal pains. Remember, your liver is within that right upper quadrant, so any pain there. Kidneys, any change in urine output. We always want it to be 30 milliliters an hour. If there's anything less than that, then those kidneys aren't being perfused the right way. And then protein in the urine, and then increased BUN, creatinine, sodium, and uric acid. those labs always tell me that there's something up with the kidneys. Placenta, that's the worst thing that could happen if it becomes so severe where there's so much vasoconstriction within the arteries supplying the placenta that baby's not going to be getting enough perfusion, not enough oxygen, not enough nutrients. So that's a key thing to monitor for. Skin, generalized edema. Edema because of there's not enough protein within the blood. Upper and lower reflexes, they're very irritable. So you want to think that someone with preeclampsia, there's going to be very high deep tendon reflexes. If magnesium works too well, then we can have absent deep tendon reflexes, in which we're going to have to administer the antidote. Poor placental perfusion. If you have poor placental perfusion, that baby can't grow right. That placenta can erupt from the uterine wall, or fetal distress can happen, of course, because there's not enough oxygen getting to the baby. Those are your labs, especially if it's that we're always going to be looking for a patient with preeclampsia, but especially if it's severe, we're going to want to pay attention to all of these. Make sure that every single organ in the body is getting perfused right, because with severe preeclampsia, it's affecting a lot of different organs. Management of preeclampsia. This is when it's only elevated BP. It's not affecting like the body system just yet. So they're going to be having you want to tell them activity restrictions, modified bed rest, positioning on lateral side for perfusion. That's our key for everything with pregnant women. Lay on the left side, not flat, because if you're laying flat, that can actually push on the inferior vena cava and decrease blood flow back to the baby. Adequate hydration and fluids, monitor fetal activity kick counts 2 times a day, blood pressure twice daily, weight, urine dipstick, because we want to see if there's protein in the urine, because if there is like an increasing amount of protein in the urine, that's worsening sign of condition. Diet, no sodium restriction, high protein, because remember, they're peeing out all this protein, so now there's not enough protein in their blood, so we need a high protein diet, high fiber to prevent constipation, and then of course increase fetal surveillance testing. Non-stress tests, and then the biophysical profile. Inpatient therapy management, bed rest, then you have your magnesium sulfate. All right. Just know all the side effects we talked about with magnesium sulfate. We always want to be looking at the therapeutic levels. Where are they? They're right here. I don't know if you're using Tetsu on the levels, but 4 to 7 is therapeutic. If it goes above 8, then it's toxic. If it goes greater than 15, that's respiratory and cardiac arrest. Sorry, I spelled that wrong. So if it ever gets toxic, I want to be concerned, because I don't want the respiratory rate decreasing too much or the deep tendon reflexes decreasing too much. I just want to make sure, because the worst thing that can happen is that there's, really bad arrhythmias happening, like VTAC or VFib, and then this patient is coding, and then the respiratory rate is decreasing as well. So it's all things we want to look out for. And then these are your normal side effects: feeling heavy and hard to move, because it is a smooth muscle relaxant. It's a normal finding. Always remember, this is a muscle relaxant. If it works too well, then these things can happen, but it's completely normal. These patients do feel heavy. And they feel very tired as well, because they just feel heavy. Sweaty and flushing as well is also normal. All right. And then your antidote is calcium gluconate. Assess deep tendon reflexes for effectiveness. All right. Nifedipine also decreases blood pressure and stops preterm labor. All right. So your nifedipine is a calcium channel blocker, so you probably remember that from pharm. So it's a high blood pressure medication that can also help. Then you have your possible adverse effects: edema, angina, all of these things. Reduces BP faster and significant increase in urine output. All right. And then you have hydralazine. It's also a blood pressure medication as well. And then lobetalol is your beta blocker. That can also decrease the blood pressure. But your main one of preeclampsia is going to be magnesium sulfate. And nifedipine. All right. Assess fetal heart rate first. Bed rest, all the same things. Room dark and quiet with seizure precautions because if preeclampsia progresses too much, then seizures can happen. So we want as much as possible to prevent that from occurring. And then monitor BP, assess reflexes, of course, strict intake and output every hour, assess for indications of vasoconstriction. Is there a headache, visual disturbances, IV fluids, maybe restricted to decrease the edema, pulmonary edema, medications and side effects. Just know your side effects and complications of magnesium sulfate. They like to test on that a lot. And then continuous fetal monitoring, lab results, hematocrit. All right. High datiform mole. Honestly, I've never learned about this, so I put the notes here from some NCLEX sites, but I've never been tested on it, so I'm not too confident with that. So just listen to whatever your teacher told you about molar pregnancies. They went over in boot camp briefly. I believe it's when it's not a viable pregnancy and the HCG levels remain high. I remember the most. It was the what's it called? They tell a woman who have a molar pregnancy not to get pregnant for at least a year. Like, don't try to get pregnant for a year. All right. All right. Placenta previa and abruptio placentae. Placenta previa. So the main thing with this, it's when the placenta. Usually, the placenta is supposed to be up here. It's supposed to be up more. But here, it can be like, it depends on the level, but if it's completely covering the cervix, it looks like this. And we never want this to happen because we never want the placenta to come first, because if the placenta comes out first, which is the baby's main oxygen source and nutrient source, and the placenta comes out first, that baby's going to, heart rate's going to decrease and fetal demise can occur. And it will occur if the placenta comes out first. So the main thing with these patients, they're going to have a C-section, and we always have to educate them. You know, if your water breaks, let us know, because you can have a vaginal delivery. They may be able to if it's like this, but if it's completely covering or like really close to the cervix, we don't want the woman delivering vaginally. All right. Yeah, fetal demise if the placenta comes out first. The main indications is painless bleeding, painless bright red bleeding, occurring after 20 weeks, and soft relaxed uterus. There's no contractions or anything. But this is the main thing you need to know is she's gonna have painless bright red bleeding. And usually women who have the placenta previa, they'll usually notice it, say if they're having, they're pregnant and they're having intercourse, usually the painless red bleeding will happen. In that situation, diagnosis ultrasound, because we can see what the placenta is with the ultrasound. Management is just based on degree of bleeding, location, and gestation. So say it's like over here, there's a chance that we can deliver this baby vaginally just because the placenta is not completely covering the cervix. But if it's over here, I'm gonna need a C-section. Yeah, before delivery, they're gonna have to come in, and we're gonna have to monitor their care. Always tell them if your water breaks, you have to come in. Fetal monitoring, fetal heart rate, maternal vital signs, vaginal bleeding, labor labs, hemoglobin, hematocrit. That's always our priority. We want to make sure she's not bleeding too much from this site, because when she's bleeding from here. Expected management at home, limited activity with pelvic rest. We always tell her nothing in the vagina, because then that can cause the bleeding. If you like over here, and then it causes the bleeding. Daily fetal kick counts. We say 10 kicks in 1 hour. No bending or straining. Assess uterine activity daily. If there's any suspicion that she will give birth, she has to call because she can't have a vaginal delivery. Most often C-section. All the time usually, because we just don't want to risk that placenta ever coming out first. Abruptio placenta. So it's a separation of the placenta from that uterine wall. It could be entire or partial. So if it's entire, there's a really big chance that the fetal demise is going to occur because that's the baby's lifeline to breathe and nutrients, but mainly to breathe. If it's partial, we're most likely gonna have to go in and do not us, but C-section. The baby has to the woman. Maternal risk factors, cocaine, hypertension, blunt force trauma, multi-fetal pregnancy, cigarettes, advanced maternal age, high parity. Like she's been pregnant many times. So the difference in these symptoms, if you're comparing it to placenta previa, which they like to do a lot, is that with this woman's going to be in intense pain. Intense, like very intense. This one was with placenta previa, it's painless, bright red bleeding. Here, she's going to be in intense pain, and she's very irritable. The uterus is rigid, increased abdominal girth, and then port wine colored amniotic fluid. And then fetal demise can happen. We can be seeing a decrease in fetal heart rate and everything. And if it's a complete fetal separation, complete placental separation, there's a big chance that the baby can die, will die because it's just completely teared off. So mortality is up to 50% with this. Guided. Okay. Our focus is on saving the mom when this happens, because there's a really big chance that baby is going to have fetal demise. Rapid cardiovascular assessment of mother and then fetus. 2 large bore IV lines for fluid replacement because she's going to be losing blood. Okay. Maternal vital signs we always know are signs of hypovolemic shock, hypotension, tachycardia, pain and bleeding, fetal heart rate. Ensure adequate tissue perfusion. Mother should always be laying on the lateral side. We never want a woman to be laying flat because that can decrease the blood pressure. All right. Lab results looking for DIC, psychological support. Okay. And then this is just a little graph of like the difference between the two. All right. Just know that this is darker blood. This is bright red with placenta previa. There's no pain here. Uterus is fine. Over here, it's firm and rigid because we have a complete separation happening of the placenta. And then fetal distress, of course, with placental abruption. All right. Any questions about placenta previa or the abruption one? Okay. And then you have medications used for medication-induced abortion. These are the main ones. Misoprostol, Cytotec. It just stimulates uterine contractions. It helps the woman contract so that she can expel all that pregnancy tissue. And then you have a combination of this one and this one. I don't want to say this one. It helps stimulate those contractions. This blocks progesterone. Progesterone helps a woman maintain a pregnancy. It thickens up that endometrial lining, and that's what a woman needs to keep that lining. And we never want it to shed because if it's shedding, that means she's not carrying the pregnancy. Okay. Whenever someone has an abortion, if that's spontaneous or they wanted it to happen, you always want, if there are H negative, the mom, she needs RhoGAM, and if the baby's Rh positive, she needs RhoGAM. Whenever there's a chance of fetal blood mixing with maternal blood and the mom's Rh negative and the baby's Rh positive, RhoGAM needs to be given. Okay.
Can I just say something real fast?
Yeah.
So I'm Rh negative and I've had 3 pregnancies, and in my pregnancies, I've had bleeding, so they would give me the RhoGAM shot no matter what. And
Right.
after delivery, they still gave it to me, even though one of my kids was negative.
Right. So they usually do that, I believe, 28 weeks and then postpartum. It's just like any chance there's like maternal and baby blood like mixing, even if it's mainly to protect future pregnancy. So if you ever get pregnant again, it's to help prevent ever like antibodies developing for future pregnancies. Does that make sense? It's mainly just to protect like you from getting antibodies because we want to protect always the next baby in line. Um, any questions with anything? Okay. Let me see how many pages are left. I'm gonna have to move on to PEDS in a bit. All right. I'm just gonna look real fast. Okay. Gestational diabetes, that's diabetes only during pregnancy, but anyone who gets gestational diabetes, they are at a higher chance of getting type 2 later in life. That happened with my mom. She's pregnant with me, had gestational, now has type 2, like I think when I was like 6 years old, so like 6 years after delivering. So there's a really, really high chance of getting type 2 later in life. But that's why it's always important to exercise and all things like that, just to prevent your chances of getting type 2 later in life. Insulin therapy is the first line pharmacologic treatment for gestational diabetes when lifestyle modifications are not enough. Insulin does not cross the placenta, making it safe for the fetus. So they're mainly going to be dealing with injections. Short acting, intermediate acting insulins are most common. So short acting, like your Humalog, which works in like 30 minutes. And then you have your oral hypoglycemics avoided during pregnancy because they can cross the placenta that can affect the baby. Concerned about fetal hypoglycemia. Oh, all right. Just know we mainly want to do insulin because it doesn't cross the barrier. And then you have caput succedaneum. So this is when the baby's head becomes elongated like this. And this is completely normal. It's when the baby has swelling at the very top when molding occurs. So molding is when that baby is coming out of that birth canal, and the baby has fontanelles, so the cranial bones sort of just like go over each other so that baby can come out nicely. So yeah, that's completely normal. We would just note it. There's no interventions though. The swelling goes down in a couple days. And then cephalohematoma usually happens when they're using like a vacuum to help or to a vacuum to help deliver the baby. But they put it on the baby's head and it helps like basically like suck the baby out with a birth canal. And a cephalohematoma can happen where there's a blood collection over here. The main thing with this is that we're going to want to monitor for jaundice, and it's on one bone. This was on multiple bones, but remember, there's no interventions with this. It's completely normal. It happens a lot, and the swelling goes down. This we have to monitor for jaundice, because we know the worst thing that can happen with jaundice is kernicterus. So we just want to prevent that as much as possible. All right. So that's that. Newborn screening test. We check for PKU, which is when they can't break down like proteins. Congenital hypothyroidism. So with hypothyroidism, low levels of TSH and those thyroid levels can cause like constipation and just everything to be slow and low. It can cause weight gain, things like that. It can also cause growth and mental delays as well, especially if it's congenital. Galactosemia, and ability to produce galactose, milk sugar, leading to liver damage and cataracts. Sickle cell is one of the main ones we test for. Just because there's a lot of complications associated with sickle cell, like those vaso-occlusive crises, and then also cystic fibrosis, because cystic fibrosis, there's a lot of complications with that. The main one being respiratory infections. And then other conditions, maple syrup urine disease, and this one, I've never heard of it. if I saw an ATI. Severe combined immunodeficiency, hearing loss. All right. Thermoregulation and phototherapy. The main thing with this is that we don't want the baby losing too much heat, because if they're losing heat and their temperature goes down, that can cause the respiratory distress, but then it can also cause hypoglycemia, and then also can cause metabolic acidosis. So we just want to prevent that as much as possible. And we prevent that by, when that baby comes out of mom, you want to dry the baby fast and then place the baby skin to skin with mom, wrap the baby in a blanket, hat on the head, preserving all that heat, preventing all heat loss. All right. Yeah, okay, I just said that. So this is, it's like a picture that my teacher showed us last year, just saying like decreased temperature happens, then, you know, it increases the metabolism that we're, because your body tries to compensate. And then we have a decrease in glucose, which can cause hypoglycemia. And then, you know, these all just go in hand, and then respiratory distress can happen, respiratory rate increases, oxygen decreases. If metabolic acidosis can happen, but if it progresses, then we're retaining too much carbon dioxide. Respiratory acidosis can occur. I don't know if it's using the test like on those things though. And just knowing that these are all correlated with one another. Okay. So it's always important for us nurses to always remember to do those things, because if you fail to really dry that baby off and preserve that heat as much as possible, and that happens, that could be put on you. All right. Just saying all the same things. Yeah, if you know you don't fix a baby's in respiratory distress, they're going to become hypothermic and hypoglycemic. So they just go hand in hand. If you don't fix, say a baby was born with low blood sugar levels, and you don't correct that, temperature will decrease, respiratory distress will happen. This picture is just showing that one can lead to the other two. One can lead to the other two is mainly what it's saying. All right. Okay, newborn characteristics related to thermostability. Skin is thin, less sub-Q fat. And this is important to know, because all these like NCLEX specialists like Zach's about this, like babies have the inability to shiver and no goosebumps for the first 3 months of life to produce heat. So if you see a baby shaking like a newborn, that's not normal. It's called tremors, and it's usually related to hypoglycemia. All right, newborns maintain a flexed position to decrease the exposure of body surface to heat loss. This is a normal temperature. But skin to skin, first line of treatment for hypothermia, because babies are coming out of a very warm environment in the uterus and they come out to this colder environment. So we place the baby on warm mom. And these are the different types of heat loss. So we have conduction, where movement of heat goes to objects. So we always want to warm up a stethoscope or anything. And this is direct contact. Direct contact with something that's cold, heat is getting lost. Convection, air movement. That's why we close doors in delivery rooms, close the windows, because we don't want a cold draft coming in and then the baby losing heat, because their heat's going to be following that air. So convection is associated with air movement. Evaporation, it's the most common one, and I feel like it's the most easiest to remember. So whenever a baby's wet, then they're losing heat that way. Radiation is when transfer of heat to cooler objects that are not in direct contact. So that's why we always educate, parents, don't place a crib right below a cold window, because then their heat's going to be moving towards that cold window. So it's something that's not close to the baby, that's not in direct contact with the baby. And then effects of cold stress, just repeating itself: increased oxygen needs, respiratory distress and hypoxia, hypoglycemic, increased risk of jaundice. And then you have your pregnancy signs and verification. So you just want to know what's subjective. This is subjective presumptive symptom. So this is what the woman is, why she thinks she's pregnant. This is what she is experiencing. The doctor can't tell her what she's experiencing. This is subjective. So fatigue, she's telling the doctor she hasn't had her period, nausea and vomiting, urinary frequency, breast changes, quickening, where she feels the baby's movement, skin hyperpigmentation, which is a side effect on women. Um, Objective probable signs. This is physical signs that the examiner, like the doctor, is going to be noticing, or even the nurse. Chadwick sign, just the bluish purple coloration. Goodell sign is softening of the cervix. Hager sign is softening of the lower uterine segment. Abdominal enlargement. Braxton Hicks contractions, which are those false labor contractions. Ballottements, basically, it's cut off. That's basically when the examiner puts their finger up and they push up, and then the baby comes back down. Then positive pregnancy test is under objective probable signs, because pregnancy tests are like 95% accurate. So they're not going to be like, okay, it's positive where it's 100%. No, pregnancy tests aren't completely accurate. All right. And then we also test the blood for HCG levels. So HCG is the pregnancy hormone. We know someone's pregnant because those hormones are elevated, but also if like progesterone is elevated as well. Positive signs, we hear a fetal heartbeat, fetal movement felt by an experienced practitioner, and then visualization on ultrasound where we can see it. So only if you hear, feel, or see baby, then you're positive that woman is pregnant. Is this the last of it? Okay, this is the last of it. I put a little bit of extra notes in the last couple pages. I'm not sure if your teacher's gonna be asking about like variability. But okay, your fetal heart rate patterns. So I always look at this acronym to help me. So your the ones that are normal is early and accelerations. These are completely normal, so don't be alarmed with those. Variable and late, I'm going to be concerned, because variable is telling me that there's cord compression, that baby's probably laying on the umbilical cord, and that's basically, the baby's really cutting off the oxygen supply to them because they're laying on it. If they're having late, like placental insufficiency, that's because that artery is not it's not being perfused right, and there's not enough perfusion getting to that placenta. So we mainly see late decelerations with preeclampsia, because you want to think like preeclampsia, high blood pressure, vasoconstriction. So if there's so much vasoconstriction happening, then of course you're going to see the placenta not being perfused right. So of course you're going to see late decelerations. Variable, the main one we're going to think here is cord compression. The baby's laying on the umbilical cord. So this is what they look like. So like I said, variable. So just do the acronym VEAL CHOP, and then it adds up. So VEAL CHOP. So V lines up with C, so I know it's cord compression. And so this is, I'll just show you what it looks like. Okay. So with this one, they're pretty easy to recognize just because they're very like they're very sharp. It's not supposed to be sharp like that. And it's not even happening in correspondence. So this is the contraction on the bottom, and then this is the fetal heart rate strip up here. So like an example would be early decelerations. These are completely normal. It just tells me that the baby head's being compressed with contractions, which is normal, of course. We want that baby to come out through the birth canal, and if there's head compression happening, that's completely normal. It's just telling me that the baby is making its way throughout the birth canal, and of course their head's going to be squeezed out because the birth canal isn't super big. But with early decelerations, that's all it's telling me. It's telling the baby's head's being compressed, so the fetal heart rate drops a little bit. That's completely fine. And then it goes right back up to normal when the contraction's done. So this is the contraction the woman's experiencing. So the contraction, and then up here with the fetal heart rate, it just decreases a bit with the contraction, which is fine. And then when the contraction's done, then the baby goes back to normal. That's completely normal. With variable, that's telling me that there's cord compression. So It's very UV shaped. It's not even corresponding with the contractions. It's just very all over the place and very UV shaped. And that's going on with that. So your priority is going to stop Pitocin. We want to stop those contractions, right? Because it's making the problem worse. Um, and then if not on Pitocin, priority is to reposition the mother. Always get those questions a lot on like Archer. Always reposition the mom to her side. We want to get that baby off the umbilical cord because they're most commonly laying on it. That's what's causing this. And then, of course, oxygen, IV maintenance. So those are going to be your 4 key priorities with the ones we're concerned with. We're going to want to stop the medication. We're going to want to reposition the mother, oxygen, and then IV maintenance. Those are the 4 things you have to remember. And notify provider if these didn't work, because then there might be something else wrong. And then light deceleration. So think veal chop. L goes with P, so placental insufficiency. So that placenta is not being perfused right, most commonly because of preeclampsia and high blood pressure, because remember, high blood pressure causes vasoconstriction. So this is what we're seeing here, where normally when a woman has the contraction, it's supposed to mirror, but it's not mirroring here. It's happening after the contraction. That's telling me that the placenta is not being perfused right, and everything's delayed. Sorry. So our priority here, where am I? Is going to be to stop the medication, place her on the side, because that's always the best on how the placenta is going to be perfused on the side. We never want a woman laying flat. Oxygen, and then increase rate of IV maintenance, and then notify the provider if things didn't work, and then most often going to have to prepare for a C-section. All right, so remember, these are your key things here. Stop the medication, reposition the mom, oxygen, IV, notify provider if it didn't work. Same interventions, but just know why though. Like, of course, we're going to want to place her on the side because we want that placenta to be perfused better. And maybe it's not being perfused when she's laying flat, because that's usually the case. And then here we want to get that baby off of the umbilical cord. So we want to reposition her just to get the baby off. So it's the same interventions. Early, completely normal. It's just telling me that, the fetus's head is being pushed, which we want. That's your acronym. Same notes here. I just included additional notes, but same thing, that a normal heart rate is 110 to 160. Anything decrease for long periods of time is concerning. Persisted for at least 10 minutes, because babies' heart rate fluctuates when they're in the uterus. It fluctuates and it's all over the place. And that's normal. It happens. I don't think I saw this on your blueprint. I just included it. All right. I think that's it with OB. Is there any questions at all? Okay. Does anyone have any problems with any of the questions I posted, or if you want to go over one? Unless we can just move to PEDS. Okay, I'll just move on to PEDS then. All right, I think there's a lot of pages here as well. So do you guys have a specific condition you want to go over, or if you just want me to go in order? All right,
Can you go in order, please?
You can go in order.
Okay, I'll go in order. Okay, so cystic fibrosis, this is congenital, so it's inherited. All right, so the main thing with this is you want to think thick, sticky mucus. With bronchitis and things like that, yeah, you have mucus in the bronchioles, but it's not it's going to be thick, but it's acute, manage it with fluids and everything, and it goes away. But with this, these patients are consistently producing thick, sticky mucus. And it's not just thick, sticky mucus in the lungs, it's all over the body. It can be seen within that pancreatic duct, pancreatic duct, and that like common bile duct supplies so much, like the liver, the pancreas, um, what else? Liver, pancreas, and gallbladder. It just supplies everything. So we want to focus on that. But then there's also mucus builds up within the intestines as well. So that's why we talk about pancreatic enzymes as well. They have to take that every time before they eat because it helps them digest the food because they're not really digesting food right. Because also the pancreas isn't working right. The pancreas isn't working right because that common duct is blocked with mucus. So that pancreas can't do its job by releasing digestive enzymes that it's responsible for. Our pancreas does that. It's important for releasing insulin, so these patients can get diabetes, and it can be common, especially if we're not managing those mucus secretions right. So it is common for that. And then the pancreas is also responsible for releasing digestive enzymes into the stomach so that a patient can digest food. So if we don't have digestive enzymes in our stomach, we can't digest well at all. So that's where the pancreatic enzymes were. I think I posted a question on that. That's where that comes in. And that's why it's really key because these patients aren't digesting right. Or digesting food at all. So all right, I'm just gonna cover the main things. All right, increased viscosity of mucus secretion. So they're thick, very thick mucus. So when there's really thick mucus, that is a site for where bacteria can grow. When anything becomes stagnant and it just stays there, that's a site for bacteria to grow. So if we have really thick, sticky mucus in our lungs and we're not really taking a lot of interventions, then that's when these patients, they're very prone to be getting pneumonia and respiratory infections. So it's very important to help them, especially the pediatric patients, to help them expel those mucus secretions within the lungs. So we do CPT, so where you're like cupping your hand and like tapping on the lungs to help like loosen up those secretions. So then the patient can either like cough them up or you can suction them and get those mucus secretions out. We want those mucus secretions out. We never want them to stay there where bacteria can now grow on it. That's the main thing with it. Always want to prevent respiratory infections. So we also want to take into consideration the small intestines, then the pancreatic and bile ducts as well, because if those are also impacted, then they can't digest food the right way, because the small intestine helps with that. And then the pancreatic duct releases those enzymes. And then your bile ducts as well. Bile helps you digest food as well. The gallbladder stores bile. All right, so we just want to make sure that these organs, there's not too much mucus around them so that these organs can work the right way and release the enzymes they need. All right. And then they're prone to sinus infections because you want to think thick mucus in their sinuses. Lungs, we just covered that. So very thick mucus there. So they're very prone to be getting infections. And that's the main way that cystic fibrosis patients die, because they get a lot of lung infections and that can cause them to die. And that's the main cause of death for them. Crackles, wheezing, diminished breath sounds, retractions in those children, shortness of breath, tachypnea, tachycardia, of course, digital clubbing. You only see digital clubbing, so those thick fingernails with chronic hypoxia. So someone has had a chronic condition for a very, very long time. That's the only time you'll see digital clubbing. And there's like a different angle to the nails, and the nails are very, very thick. Eventually, this leads to pulmonary insufficiency and death. And then bacterial infection of lungs that lead to respiratory distress is the most common cause of death with someone with cystic fibrosis, like I said. And then skin, high concentration of sodium and chloride. So very salty after a kiss. So they're very like salty. So that's usually how we there's a test to see if someone has cystic fibrosis, and they're measuring how much sodium their sweat is. And if it's super high, then they'll get diagnosed with cystic fibrosis as well. But we also do that in um the the test I was talking about. I forgot the word. The newborn test. Liver blocked biliary ducts, pancreatic blocked pancreatic ducts. If the pancreatic ducts are blocked, then the pancreas can't do its job. It can't, release insulin the way it's supposed to do. So those patients are prone to getting diabetes. And then also the pancreas is also responsible for releasing digestive enzymes. So it's not, and it releases digestive enzymes to the stomach. So if it's not doing that, then the patient can't digest food the right way. And then also your liver produces bile. And bile helps us digest food as well. So I'll just write this. So the liver produces bile, and then the gallbladder, which sits on top of our liver, it stores bile. And you want to remember that bile helps bile digest food. Bile is released into our small intestine, and it helps like digest food, put that bile in there, and then just how food can go within the small intestine, large intestine, out the rectum. It's just the way it flows helps our food get digested well. And then pancreatic ducts. Your pancreas produces insulin and digestive enzymes. So it's basically like if the pancreas can't say they're blocked, now the liver can't do its job, bile can't help digest food. Pancreas can't do its job, now this patient's getting diabetes, and now the digestive enzymes are not being released into the stomach. So that's why we talk about pancreatic enzymes that they have to take before eating a meal, because those enzymes are going to help them digest food. Intestines cannot fully absorb nutrients, so we have to think about nutrition when taking care of these children. Digestive system, paralytic meconium ileus at birth, failure or delayed failure of more than 40 hours to pass the meconium. That's usually a sign at birth that they have this. That always comes up a lot. It's always a concern if a baby has not pooped within 24 hours. We always want to see that patient first, that baby first, over any other baby, because this is an emergency. We always want to, because babies should be passing their first stool within the first couple of hours. They should not be not having their first stool within the first day. Steatorrhea is frothy, foul-smelling stools. So steatorrhea is when there's protein. Let me just verify this because I feel like I haven't heard this word in a bit. I just want to make sure I'm right. Yeah. Okay. So it's excessive fatty stool. So the rationale behind this is because these patients aren't able to, digest food the right way. They're not able, because they don't have those digestive enzymes. Food's not being digested well. Fats and oils are not being digested well. So now this patient has a fatty stool. So there's fat in the stool. And that's what bile does. It helps digest food, and it basically how do I say it? It helps with those oily foods. It helps it to not become super oily where now you're having excessive GERD and things like that. It helps fatty foods as well be digested as well. So that's where bile comes into play. And then malnutrition and growth failure despite adequate caloric intake, because they're not able to digest food properly. And then deficiency in vitamins A, D, E, and K, because they can't absorb fats. Those digestive enzymes, they're not being released into the stomach. It's not helping. The bile is also not being released. It's just not helping them absorb nutrients and really digest the food. And then reproductive, unable to reproduce because it affects their male reproductive female reproductive organs as well. Yeah. All right. Diagnosis. If it happened later or you diagnose them later, it's because of it's a frequent upper respiratory infections. All right. Prenatal screening. All right. We do this in all states to check for if they have it early on. Some children will come from a different country and haven't been screened, then we'll do this test. I talked about it. So usually if the sodium chloride level is above 60, then they'll be diagnosed. So it's basically they put a mild electrical current, like a disc, into the skin, and it basically causes a patient to sweat, and then we're going to measure the sweat. And if it's above 60, then they're going to be diagnosed with it, cystic fibrosis. Maximizing lung functioning. So we want to do a respiratory assessment. That's always our priority because, like I said, there's so much mucus within the lungs, and then pneumonia could happen. And if pneumonia happens, that can lead to death in these patients. So that's our priority, our respiratory assessment. Our goal is always to promote the removal of the secretions. All right, so if they do get an infection, IV antibiotics, manage pulmonary complications, forced exhalation. The main thing is just managing the secretion, CPT and postural drainage. So if you think back to med surg, CPT is when you're like cupping your hand and you're like tapping on the lungs, and basically that's helping like loosen up the secretion so now the patient can cough it up, or you the nurse can suction out that mucus. And then postural drainage, where you're basically like decreasing the head of the bed so much where now mucus is now being drained that way, and that facilitates the secretions coming out. And then vibrations to loosen secretions. There's this chest jacket. Oh yes, that's it. The vest airway clearance system. That it produces like vibrations and it helps loosen the secretions as well. It's like a vest that they put on. I think I put a picture, unless I didn't. All right. Okay, and then humidified low flow oxygen. We want humidifiers, they help as well. Maximize nutritional intake, so high calories, high protein, dietary supplements, A, D, E, and K supplements. All right. Should receive routine immunization, so they are prone to infections, medications, a mucolytic to loosen and thin pulmonary secretions, antibiotics, and then all kids will take this, which is pancreatic enzymes for their entire life, because like I said, like pancreatic enzymes normally in their body are not being released because of that thick mucus blocking the pancreatic duct. So that's where pancreatic enzymes come in there, and it helps them absorb key, vitamins and fats and carbs. Given with all meals and snacks, so that every time they eat, they must take the prescribed pancreatic enzyme. So always. All right. Any questions with cystic fibrosis? I know there's a lot of notes in there. Okay. Next is developmental. So these questions should be like easy questions, just because like some of them are like common sense the way they ask it, but toy selection. With infants, you want to give them any toy where, that's going to promote sensory motor stimulation, where something that they can play with, and feel and touch. They like to feel and touch, and that's how they explore and learn new things. So it's always things like that. Anything fluffy, crunchy, sounds, colorful. They say mirrors as well, board books, stacking toys or balls, just anything that they can touch or play with, because that helps promote them to learn about how different things feel, things like that. And infants do play by themselves. They're not gonna play with another person or next to a person. They're solitary. They do not know how to share yet. And then tummy time. I don't think there's anything to do with it, but tummy time is important because we want to promote them to obviously lift their neck muscles, use the neck muscles, but also prevent plagiocephaly. So if a baby's laying on their head all the time, that can cause a flat head in the back and maybe even some like pressure injuries too. Um, Toddler, they engage in parallel play. They do not know how to share, but they can play next to another toddler. And then imitation of female and male behaviors, and then toys and their types of toys is just anything that can, because toddlers, they're at the age where now they're going to start walking and running and things like that. So anything that can promote walking or running and help develop motor skills, so like the shopping carts or balls, large crayons, coloring books, vacuums, balance beam, anything that's going to help them promote those motor skills. Preschooler, the main thing with them is they're very dramatic and imaginative and very creative. So they're very organized with magical thinking. They like to play and dress up. An associative play where they're learning to play with others, and then school play, organized playing with others, mainly like baseball, football, things like that. And then adolescence, peer activities, electronics, readings, and sports. Preparing a child for a procedure. Um, with this, infants, obviously you're not going to be telling them, oh, you're going to have a procedure. They don't know what you're saying. So just comforting them, allowing them time to warm up, talk softly, things like that. Just, you're not, just, because the whole thing with infants is that it's either they're trustful of you or there's mistrust. So that's how you promote that. Toddlers, this is just talking about the main way how you communicate with them, but you just prepare toddlers right before the procedure. I know I included a little bit of extra stuff just because like my teacher did last year. But the main thing is to prepare toddlers right before the procedure. They're not going to really understand what you're saying. And then preschoolers prepare about 1 hour prior to the procedure. If you want to maybe explain that procedure, they're very magical thinking and very creative. So you can use like puppets or storytelling things to explain it. All right, school age. That's like your, 8-year-olds, 10-year-olds. They know things, so it's not like they don't know anything. So you need to prepare a few days before the procedure. So explain it to them. If you want to use diagrams or books or models, allow them to process it, because school age children, they're not dumb, they know what's going on. And then adolescents, you can give them up to a week in advance to prepare for a procedure, respect their privacy and confidentiality, of course. Use appropriate medical terminology, but explain terms clearly, encourage expression of feelings, involve them in decision making. All right. Medication administration. The whole thing with pediatrics is that everything's weight dose, so it depends on weight. Like with adults, you can be like, okay, you'll read the bottle and it says, all right, take 2 tablets of acetaminophen every 4 hours, but we can't do that with kids. There's not a lot of research with how many you can give, so it's very much weight based. Verify the ID bands. Within the pediatric units, they usually have a picture with the ID bands, because sometimes children like to lie as well, their names and stuff, especially your infants and toddlers. The parents are not always going to be there, so you always need to scan the bracelet, and usually there's a picture with it. Precise measurements. We can use oral syringes or measured cups. This is a big thing. Never a household spoon, because it's not as accurate as you using like an oral syringe or like an actual measured cup. Be honest with children. Offer praise after medication administration. And this is how you're going to administer medications for each age range. So with an infant, you can actually involve the parents during medication administration whenever possible. So, you do all your checks of medication and administration, but the parent can actually hold the child and give it to them if they're comfortable doing that, the parents. Just because infants are more trustful of their parents. So it is completely fine. As long as you're doing your medication checks and you're watching the mom give that medication to the child, it's completely fine, because it's just the child can be more comfortable that way too, especially the infant. Stranger anxiety is common. Sometimes allowing a parent to give the medication with the nurse observing minimizes distress. Cuddle, rock, and soothe. to provide comfort. Insert oral medication slow. This is the main thing I test on too. Insert oral medication slowly into the side of the mouth to prevent aspiration. So aspiration is when, liquid or food gets into the lungs. We want to prevent that. Never mix medications in full bottles or formula or food, because the main thing is with that, like, if you've ever mixed medications in like on a med surg unit, it is normal, but we tend to give it in like a little bit of like an applesauce, because you want to make sure that that patient is going to be finishing that food. But with babies, we don't know. They get full fast sometimes, so we never want to mix medications, especially with our infants, just because there's a risk that they're not going to finish it and they're not getting the complete dose. So rule of thumb, just don't do that with children and mix medications in food or liquids. Toddlers 1 to 3. Their favorite word is no. They just like to say no a lot because they want autonomy. Um, so you want to give them choices. You don't want to, say, no to them, like you can't have this, things like that. You want to just ask them and give them like a sense of autonomy. Do you want the pig medicine or the red one first? It's all about giving choices, and that promotes that autonomy for them, because if you don't get that autonomy, that can lead to developmental problems later. So involve parents to hold or comfort the child, administer meds quickly, and reward positive behavior afterward. Therapeutic play with the stethoscope can help reduce fear. Watch the risk of aspiration of the toddlers crying while receiving oral meds. Preschoolers, simple explanations, involve them in care. Therapeutic play, get them familiar with equipment. Give praise and use colorful band-aids when appropriate, and then allow choices when possible for a sense of autonomy. School age, honest, clear explanations for them. All right. Alex, if they have any questions with meds. Adolescents, approach them similarly to adults. All right. Preschool development. I don't know if your professor meant like physically or mentally, but I just included everything. So with this, the main thing is initiative versus guilt. So this is when they start to initiate play with others, group play, get along with others, cooperation, sharing, things like that. And then if they feel guilt and not a part of the group, they felt left out or experienced disapproval. So that's like Erickson's theory of all children. They have their own development. This one's initiative or skill. Cognitive, start to use their imagination, so magical thinking, imaginary friends, animism, so inanimate objects given life, all things like that. Advancing gross and fine motor development, very agile while standing, walking, running, and jumping, scribbles freely. They're just your fine motor development is more like coloring and everything. The gross one is more like using your bigger muscles, like your legs, like for walking and running. All right, communication and language by 5 years of age, over 2,000 words. The main thing with their play, it's very imaginative and creative. So like I said, superheroes, princesses, tea parties. Associative play, where they can now play with others. Toys, anything imaginative. That's what you're going to pick, like costumes, superheroes, things like that. Vivid imaginations. And then we say after 3 years old, after toddlerhood, there should be no naps at all, because we need structured bedtime routines. So they can sleep for 12 hours per night, but they should have no naps during the day. They're common for having nightmares, night terrors. All right. They're also picky eaters. Food fads, where they like love one food, they're obsessed for one food, and now they don't like it the next day, where they're very picky. All right. And then you have separation anxiety. So that's the children's reaction to illness and hospitalization. So basically they feel like a loss of control. It's this removal of family and familiar surroundings, like in their home. So infants, they can have stranger anxiety and separation anxiety. So they get very fearful of unfamiliar people between 5 to 6 months of age. Toddlers also experience separation anxiety. It usually goes away after like 6 months for a bit, but then it comes back. Or around 18 to 24 months, they say, and then they don't want to be separated. Preschoolers can also have separation anxiety. Um, it's that. And then there's poison prevention. Just the main things: keep medications, cleaning products, cosmetics, other chemicals locked and out of reach, of course. Safety latches are important. We focus on lead poisoning a lot because it's common, especially in like older buildings have paint that have lead in it. So if those walls are like chipping and then lead is exposed in the air, then it can impact children, and those lead levels can increase a lot, and that can actually cause developmental delays. So it's prevention by removing sources like lead paint, and some old toys used to have lead painted on them. So they don't really make that anymore. That's not really a concern, but they're mainly like the old buildings and walls chipping. All right. I just want to go to the more harder things. Sleep hygiene. This just tells the whole thing with it. Infants do need a routine with sleeping, so they need a routine. It helps them develop trust. That's the main thing with it. Because with infants, it's either, with according to Erickson's, trust or versus mistrust. So for them to have trust, they need to have a nice routine and things like that. Bedtime routine. They do the bedtime the same way every night. PJs on, put a clean diaper on, brush their teeth, read a book, sing a song, put them down to sleep. And they need to do this same time every night and develop this routine early. And then infant, it's always important to talk about SIDS prevention, so sudden infant death syndrome. So they need to sleep on their back, firm mattress. Breastfeeding also helps prevent SIDS, and then nothing in the crib. So there should not be a lot of toys in the crib. There shouldn't be a teddy bear in the crib. Really, we really don't want anything in the crib. No bumpers, a cool room, and no smoking. And parents shouldn't be smoking. It helps prevent SIDS. Um, Toddler, they can sleep 12 to 13 hours per night. Nap stop by 3 years of age. Consistent bedtime rituals that started when an infant. Night waking, some will self-soothe, some may need to be tucked back into bed. Preschooler, they can sleep 12 hours per night, no naps at all. But naps need to stop after 3 years of age. Structured bedtime routines. It's always good to have structured bedtime routines. Because then that helps prevent the naps and then also just sleeping throughout the night. Nightmares are common to happen in preschoolers and night terrors as well. They make you check for monsters. And then school age, it varies. To age, level of activity, if they're very active, do a lot of sports, and health status. Sometimes they can be resistant to bedtime because they fear of missing out. Adolescents encourage 8 to 10 hours, promote healthy sleep habits, discourage electronics in bed. That's that. Any questions so far? Okay. Next is seizures. So it's like all things you've learned before. It's just a sudden, abnormal, uncontrolled electronic discharge in the brain. And when there's different types of seizures, I don't think you're a professor or teacher. Not. You have those tonic-clonic ones. You have those absent ones. But the main ones with children is the ones when they're moving, like those grand mal ones. So that like rhythmic jerking. So the most common type of why children are going to be getting seizures is because of a fever. Most common in children 6 months to 5 years. Rapid rise in temperature greater than 102. Typically self-limiting, lasting less than 5 minutes. If anyone has a seizure greater than 5 minutes, that's not normal, and that's a sign of, just write it. That is epilepticus. That is when there's a seizure happening more than and longer than 5 minutes, and that's not good because seizures are very concerning because patients who have seizures, they cannot protect their own airway. So that's why we have to turn them to the side, loosen restrictive clothing, and your main concern with seizures is safety. Everything is going to be regarding safety. And this one does not include epilepsy or brain damage usually, because seizures are a cause of an underlying condition. If it's not a cause of an underlying condition and you ruled out any other causes, then that patient is diagnosed with epilepsy. It's basically just you have to rule out all these other things that can cause seizures, like hyponatremia, hypernatremia. You rule out everything else. Fever. This patient doesn't have a fever. Labs are all within range, but this patient's having a seizure, and we can't seem to find another explanation for it. Then they're going to be diagnosed with epilepsy, and I believe it's like 3 times in 1 month. I think that was how they diagnose epilepsy. Generalized seizures affect both sides of the brain, include tonic-clonic seizures. So that's the one where the muscles stiffen and then the jerking. That's the most common one that you see probably on TV shows. And then the focal ones affects one side of the brain, so it may cause unusual movements or sensations without loss of consciousness. This one is a loss of consciousness. Should have wrote that. Nursing care during seizures. I feel like that's what's probably going to be a question, just because it's always important. Maintain airway patency, because these patients who are having seizures, they're having so much electrical activity happening within the brain, so they can't protect their own airway. So they want to maintain airway patency. So we have to position the patient on their side because we want to prevent aspiration. Protect the head from injury, remove nearby objects. You never restrain the child or put anything in their mouth ever. Loosen tight clothing. And then during the seizure, you're not going to want to be, restraining them or putting anything in the mouth. Nothing like that. You're going to want to note the seizure started, seizure characteristics, and when it ended, and then provide oxygen if needed. Like if that O2 sets decreasing, administer oxygen. We tend not to want to touch these patients when they're having their seizure, but if those O2 sets are dropping, then apply it. And if that seizure is happening greater than 5 minutes, as epilepticus is occurring, you're going to want to administer a benzodiazepine because that's going to stop that seizure. That medication works fastest. Your lorazepam. Your post-ictal phase, keep the child on their side. Check their vital signs and then reorient. We want to check the level of consciousness because it impacts brain function, and a very long seizure can cause permanent neurological damage. So we want to check for all things like that and allow the child to rest. Is when you check all your checks, check the level of consciousness, your alert, if they're alert oriented, things like that. Medications for seizure control. So acute management. When we're talking about acute management, this is during a seizure, what you're going to want to do. You're going to miss lorazepam or diazepam. These are your benzodiazepines. Remember, your benzos end in pam or lam. And these work really fast. And we do this IV, and it works really, really fast. And we're going to want to do an IV. Nothing in the child's mouth when they're having a seizure, IV. And it works really fast, your benzos. And then maintenance therapy, you can use those other seizure medications, like if you think back to pharm, like phenytoin, carbamazepine, valproic acid. And then I don't know how to say this one. I know this one's another one, but this is just maintenance therapy. If that child is diagnosed with epilepsy, we're going to use these maintenance medications. But say it was due to a fever, a very high fever, and it caused it, and it was, lasting a while. We'll answer this for acute management. But then once we get that temperature under control, it's just acute, and then they're good. Usually maintenance therapy, it's just for epilepsy. Intussusception. So this is when the intestine, it basically like telescopes onto another in like the intestine segment, it like telescopes. Let me find a picture. I don't know if I put a picture. Let me find one. I was having a hard time like struggling like studying this last year. Intussusception. Let me show you. So it's basically when a part of the bowel like folds onto itself. So it folds on, and this is mainly like your small intestine involving Find another picture. So it's just your bowel folding onto itself. That's the main thing that's happening here. They say it like telescopes onto itself because it sort of looks like a telescope. So that's that. Yeah, so that's what it looks like. It just folds onto itself, and these children are gonna be in a lot of pain. Results in bowel obstruction because now the can't flow the right way because we just had intestines fold onto each other. All right. Most common obstruction less than 5 years of age. We don't really know why it happens, but these are your signs and symptoms. Sudden paroxysms of pain. These children be inconsolable. They're going to be a lot of pain. I mean, it looks painful. They draw their knees up to their abdomen. Very bad pain if they can communicate it, if they're old enough. Vomiting as well, because remember, whenever there's a bowel obstruction, of course there's going to be vomiting because things can't flow the right way. And sometimes they can be vomiting up feces. But the main way you're gonna know this is always the way they're gonna test you on signs and symptoms of this. Sausage-shaped abdominal mass, and that's the area where the bowel has folded onto itself, and red currant jelly stools. These are your two, well, I'm gonna say your three main ones because they're gonna be, little baby's gonna be in a lot of pain. And then you're gonna have a sausage-shaped mass, and that's where that bowel is folded onto itself, and then the red currant jelly stool. So it's stool with blood and mucus, and those are gonna be your main ones that you're gonna see. And I feel like that's gonna be a question just because those are the main signs and symptoms. All right, clinical picture, rectal bleeding, and they're very inconsolable because they're in so much pain. And then ultrasound, you can see it. Primary treatment, so we do a hydrostatic reduction if the child is stable. So this is basically when they do an enema on the child and they're pushing fluid into the bowels. And they're basically just pushing it in so that now the bowel can go back to normal and straighten out. And that's what the enema does. All right, it has 80 to 95% success, but it can happen again. So we would want to educate the parents on what these signs and symptoms would look like if it happens again. But they usually do this in the ER. Yeah, they can do this in the ER, the hydrostatic reduction. But if they don't do this, then they're going to do a surgery, which has very little less likelihood of reoccurrence than this one does. So they could do a surgery. Nursing management, assess for shock. If a baby ever loses too much blood, they can go into hypovolemic shock. So you want to think, whenever you see tachycardia and hypotension, that's a sign of hypovolemic shock. Assess for sepsis. Right. Assess hydration status. Hematocrit. I just learned this like a couple months ago, but hematocrit. I keep repeating myself. If hematocrit is ever elevated, that's telling me that the patient is dehydrated. So whenever you see hematocrit elevated, that's a sign of dehydration. And then you want to assess what are the mucous membranes looking like. And then this only intends to babies 18 months or less. The anterior fontanelle closes at 18 months. So you can see a sunken anterior fontanelle in those infants. And then poor waking as well. And then pain relief is going to be a priority. They're going to be in so much pain. So typically a narcotic. So with any narcotic, you want to monitor cardiac respiratory status. And then always have Narcan or naloxone readily available in case, that respiratory depression, things like that happen. IM administration locations. So that's basically where you're going to want it administered first. So if during your clinicals, probably notice that when babies get medications, they get it in their thigh muscle, and they get it there because the muscle within their arm, the deltoid, it's not fully formed yet. It's not as strong yet. So we're not going to use the deltoid just yet. We're going to use the vastus lateralis. In other words, just that thigh muscle, that anterior thigh muscle. So it's the preferred size for infants and toddlers. And we mainly say until the child can walk well. So anybody less than 1 year of age, always in the thigh, the vastus lateralis, because it's a chunky muscle. It's the deltoid's not completely formed just yet, but once that child starts walking around, we're like, okay, we can start going within the deltoid. So for a child to start getting a deltoid IM injection, they have to be older than 1 year of age for immunizations, because then sufficient muscle is present. So that's the thing with that. So the child must be at least 1 year of age. And a child over 3 years of age, you can give all IM injections in the deltoid. All right. Vaccines tend to be 0.5 to 1 milliliter. If a vaccine is 1 milliliter of fluid or less, you can give it in the deltoid. But if you're giving multiple vaccines, you can't give it all in the same deltoid. And then this is another site where you have the ventrogluteal, the butt, but they should be walking, so it could be like after 1 year. But the main ones is the vastus lateralis and the deltoid. They like to test a lot on this one. It's all has to do about developing muscle mass, really. That's why we give it in the thigh, not the deltoid just yet. All right, non-pharmacological distractions, accessibility to properly position a child. Okay. This is just talking about how you're going to give it, because some children, they get scared. Medication administration. I'm just going to leave that for you guys to read through. We're running out of time. And then appendicitis. Remember, your appendix is in your right lower quadrant. So whenever a child has pain there, I'm automatically going to think, oh, maybe appendicitis. So you do that McBurney's assessment, in which you put the fingers in and you palpate, push in, and then you let go, and they feel the pain when you let go. All right. Yeah, McBurney's point and localized to the lower quadrant. McBurney's point, pain becomes sharper and more intense. Nausea and vomiting can happen. Low grade fever, guarding, rigidity. All right. Okay. And then you have asthma. So asthma is that, hypersensitivity to things. Like it can be because of pollen, dust, mold, pet dander, and then all this mucus occurs within the bronchioles, and then bronchospasm, bronchoconstriction, edema, all these different things occurring, and then mucus thickening as well. So signs and symptoms of asthma around the year: tight, non-predictive cough, chronic cough, expiratory wheezing. So wheezing is always our typical sign of asthma. They can go into respiratory distress as well. You have your tachypnea, tachycardia, shortness of breath, nasal flaring. Nasal flaring is always a sign that we see this in children. It's always a sign that a child is in respiratory distress, because it's telling me that they're trying to open their nasal airways even more to breathe. And then use of accessory muscles, which can lead to barrel chest. And then restlessness is worst case scenario. Whenever you see a child that's restless and they can't sleep at all, very agitated, that's not a good sign. It's saying that the condition's worsening. Just how we diagnose the spirometry, and then regular monitoring. We go over the green, yellow, and red zone, where they basically, blow in, and then we want to see where they're at. And this just shows your interventions. All right. Treatment, avoidance of triggers, of course, medications. Yeah, so you always want to give your albuterol. That's in an acute asthma attack, we give albuterol because that's going to dilate those bronchioles. They do have that effect of increasing the heart rate, because remember, like the whole sympathetic nervous system is basically enhancing that. So we're dilating those bronchioles, but remember beta 1 and beta 2, so that tachycardia can happen. We know it was alpha 1 and alpha 2. Yeah, alpha 1 and alpha 2, because then you can have those side effects of tachycardia and things like that. So that's what you mainly see with albuterol. Assess for respiratory distress, position 45 degrees or greater. Anything respiratory, and there's a question asking, how should I position this patient? Never lay that patient flat, because patients don't breathe, good flat. They breathe better higher up. Okay, never flat. And it's always okay, your medications. Okay. I included too much like notes last year. I like included these things, but my teacher didn't even like test on these things. Like these are just different ways in which you can administer medications with like nebulizers and stuff, but I wasn't even like tested on it. It was just like a lot of extra notes. Urine collection. All right. All right, urine analysis. All right, sterile technique with catheters. We know that. Okay. Older children, clean catch midstream specimen. All right. All right, moving on to burns. So I feel like these are just for you to like read through, but burns, types of burns, you have different types. Radiation burns. I feel like they mainly test you on the interventions and your care, but you have different types of burns. You can have superficial, where it's really just like a sunburn affecting like the uppermost layer. And then partial thickness, where it's like painful, blisters, full thickness, painless because nerve endings are destroyed. Deep full thickness, it extends to muscle or bone. Your priority with patients with burns is them losing too much fluid, and then also inhalation injury as well. So this is going to be your thing. They like to test on this a lot, like fluid replacement. So don't worry about this formula. I don't think they're going to test on that. The main thing is that we need to replace fluid. We want to know how much they lost and how much they need. So with burns, it's really a thing with hypovolemic shock. Pain management with opioids, monitor for respiratory depression, infection prevention, nutrition is important because protein helps like rebuild tissue and things. So nutrition will definitely help. High protein, high calorie diet because it helps support wound healing. So of course that high protein. Measles is rubiola. The main thing with this is that you have there's usually a fever. Well, we know there's a vaccine, the measles, mumps, rubella vaccine, but some people still get measles if they haven't had the vaccine. Prodromal period, 2 to 4 days. That's where they're having the fever, but it's not like a dramatic fever. They're having a fever. And then the 3 C's, which is coryza, which means runny nose, cough, and then conjunctivitis, which is itchy eyes, because it starts as an upper respiratory infection, like head. But they also can be experiencing photosensitivity. So that's like when the sun bothers you, the very photosensitive, and maybe rashes develop as well because of the photosensitivity. And then you have Koplik spots, which is irregular white spots with a bluish white center on the buccal mucosa. Let me find a picture of this. This is a typical sign, like how you differentiate it from like other like things like. This is what Koplik spots look like. There's spots within the mouth. It's a key finding with measles. And then you have a rash. It's red and maculopapular. So maculo means it's flat, and then papular means it could be like up more, like a pimple sort of. So it can be spreading, and it's spreading on the face and neck. It spreads on the trunk and extremities, and it blanches easily and gradually turns brown. All right. Nursing care antipyretics. That means to help manage itching. Betaret. Oh wait, no. I think I wrote that wrong during last year. Antipyretics is for itching, and then you have antipyretics for fever. Bed rest, adequate fluid intake, of course, cool mist humidification, and this is actually airborne precautions. So with airborne precautions, we need the N95. Anything inhalation you think of. A dim room, low lights because of that photosensitivity. Immunization schedule, Hep B. Babies can't leave without the Hep B vaccine. They need it. First dose at birth. 2 months, they can get Tdap, IPV, polio. They're all here. I don't know how they're going to test you guys on this, honestly. I just know that Hep B babies can't leave without it. That's the main one I just know. And then you have to get their second and third dose, just depending. Fractures. There's a lot of different types of fractures. Children are vulnerable because their bones are still growing. Yes. So growth plate is the most vulnerable portion of bone, and proper healing will be bad. So we have our green stick fracture. That's an incomplete fracture. It's like when the side of the bone, just like a side of the bone is cracked. And then you have a buccal fracture, which is a compression injury. Basically, like the area like pushes in and then causes like a little bit of like swelling on the bone. Bone is squished. Then you have like a little protruding thing on the side. And then you have an epiphyseal fracture, which is important because it can impact the growth plates that are still like growing in the bones. The children aren't done growing yet, so that's why epiphyseal fractures are very concerning. And we have to make sure that they heal properly so that child can finish growing properly. Then you have a spiral fracture. That's telling me that someone has twisted their arm, so we want to be concerned with. Where's that one? I don't think I. Oh, yes, this is spiral fracture. This is concerning of child abuse. This is epiphyseal fracture. If it goes within the like growth place, we want to make sure. Most worrisome just because it's a growth plate fracture, which is never good because we want to make sure that growth plate, that child finishes growing. But now this growth plate has been impacted, so we just need to be concerned about this one and really truly make sure that it heals the right way. Let's see. Fractures, assessment, always. You do your 5 Ps. Your neurovascular assessment, that's what your 5 Ps is, neurovascular. So you have your pallor, pain, pulselessness, paralysis, paresthesia. So paralysis tests is like motor sensation, and paresthesia tests is sensation. So we're just trying to see like how much is that extremity being perfused, and if these things are happening accordingly. We diagnose with x-rays, CT scans, MRIs, ultrasounds, of course, and then we can do treatment with reduction and realignments where they reposition the bone fragments into normal alignment. We like that's like when you see in the movies where they like try to get that like dislocation or fracture in place, like things like that. They try to reposition it, where they can do like immobilize with a device, or do cast. This is traction. Traction is when you put a like pins and stuff into the bone. You can have, there's 2 different types of traction. There's skin and skeletal. With skin, you're putting traction on the skin to help keep those bones in place. With skeletal, you're putting it in the bone to keep the bone aligned and in place. And we want to keep the bone in place as much as possible, of course. For certain the child is immobile. Obviously, there's if it's skeletal traction, it's in the bone. So we want to make sure about infections and things like that and pain. So neurovascular status, leg is immobile, has cast splint, check circulation. That's always our priority, and also respiratory because they are flat. Skin integrity, want to make sure they're not getting pressure ulcers. Pain assessment, hydration status, GIGU, of course, assessment elimination, nutrition, of course, mental status, boredom, especially with our older pediatric population, but toddlers too. Ventricular septal defect. Let me see how much is left. All right. I'm going to go over this one, and lastly, just glomerular nephritis, and then cleft palate real fast. Sorry if I go a little bit over. I'm just going to go over it. Okay. So with your ventricular septal defect, you want to think back to when we said that babies have shunts within utero. So they have the foraminal valley, which is the one between it's between the right and left atrium. So if that shunt, it's supposed to close when the baby's born. If that shunt does not close, then we're going to be having murmurs. And the murmurs flow from an area from, high pressure to low pressure. So we're going to have blood rushing from um, the left atrium to the right atrium, which that's never supposed to happen in blood flow. So left to right shunting. So increased blood flow to the lungs can result in pulmonary hypertension and congestion. So there's just a lot of blood shunting the way it's not supposed to. Sorry, I think I said atrium. I meant ventricle, sorry. So you have blood. So there's basically a hole between the left ventricle and the right ventricle, which we never want happening. Because right here, blood is supposed to go to the aorta now, but now there's a shunt. It didn't close after birth, so now blood is flowing from here to here, which is not normal. It needs to go from here straight through the aorta into the organs and extremities. So it may be asymptomatic. Sometimes people are born with this and they have like a tiny little hole here, and that's completely normal. It's not normal, but it's not like super alarming if it's super small, because it's not causing like those increasing effects. So, but if it's large, symptomatic within the first few weeks of life, so they're probably going to need surgery if it develops into heart failure, where there's just blood backflowing in this right ventricle and then backflowing here. Tachypnea, dyspnea, feeding difficulties, just because heart failure can happen. All right. We treat with digoxin furosemide because our diuretics, and then digoxin helps increase that heart rate well. All right. I was never tested on hernia, so I don't want to give the wrong information. Glomerular nephritis. So this is basically characterized by it's impacting the kidneys. And the main things happen here is that there's inflammation of the glomeruli, which are within the kidneys, and it's acute renal failure. It's usually caused by a streptococcal infection of the throat or skin and wasn't treated properly. And your main manifestations is going to be protein in the urine. So whenever you hear protein in the urine, you want to be thinking not enough protein in the blood, not enough albumin, because albumin is a protein, not enough albumin in the blood. And there's also going to be sudden onset of painless hematuria, which is your cardinal sign of it. So, and hematuria just means blood in the urine. And then you have hypertension as well. Always have hypertension, and it is pretty dramatic. And mild edema as well, because usually when we have not enough protein, not enough albumin in the blood, edema occurs. Decreased urinary output because the kidneys aren't working, and maybe fever because it is caused by strep. Fatigue and lethargy, headache, anorexia, history, symptoms, and lab results. So of course, we're going to see all our kidney labs increased, and of course, I was confused with this at first, but always remember, if you're peeing out so much protein, now you're going to have low protein within the blood. So that's why it says decreased serum protein. When you see serum means blood, so decreased protein within the blood. And then elevated BUN and creatinine, renal impairment, elevated white blood cell count because of infection. Okay, I think I repeated it. And then ESR, erythrocyte sedimentation rate, that is your markers for inflammation. ESR, if you ever see ESR or CRP elevated, that's a sign that there's inflammation within the body, and that's telling me that there might be an infection within the body. Ultrasound, you can see enlarged kidneys, urine, like I said, blood in the urine, protein in the urine, and then probably red blood cells as well, of course. No specific treatment. Medications, you can give nifedipine, labetalol to help lower that blood pressure, furosemide because there is mild edema, and then antibiotics because it was caused by strep. Untreated for too long, child may have to be on dialysis. Diuresis and decreasing BP signals, beginning of resolution. So once that child starts peeing more and that blood pressure is decreasing as well, that's telling me that they won't need dialysis, it's relieving. Lab values return to baseline in 6 to 12 weeks. And then nursing management, just look at your intake and output, daily weights, because we're talking about a little bit of edema as well, so we want to pay attention to that, and your vital signs. And we're also administering a diuretic, so of course we're going to want to be looking at daily weight and taking output. All right. Labs always look at that. Nutrition status, high protein diet, because like we said, there's low, whenever you're peeing out too much protein, there's low protein in the blood, so we need more protein. All right, cleft palate, that's when there is a hole within the soft palate. So if you feel right now, you have your hard palate and then you have your soft palate. So mainly it's affecting, if it goes back to the soft palate, that's not good, but most of the time I feel like it's the hard palate. All right. And usually we can diagnose this at birth. Right after birth, the nurse has to check the palate and like do a sweep of the mouth. And if they feel that hole, then that's cleft palate, or sometimes sonograms, but sonograms can miss it. Palate, we know if it's palate, if you're feeding the baby and there's formula coming out of the nose, because the palate is right near, like the nose is right above the airway. So the main priority with a cleft palate is we want to prevent aspiration and any like respiratory infections. And that's the main thing with that, respiratory. And we want to make sure that they get proper nutrition and hydration, because of they're most likely not because of the palate, and they're not able to like swallow the right way. So that's why we modify feeding techniques. So enlarged nipple, elongated, and that's a picture of it. See how long they are? It bypasses the palate and it goes right down their throat nicely. We tend to like tell these women not to breastfeed because there's a risk for aspiration. So we prefer specific bottles for the baby, so it bypasses the cleft palate. You want to make sure that they're swallowing good, rest, give them breaks. They need breaks in between when they're, when you're giving them milk. All right, almost same thing. They do cleft palate repair by 9 months. Concerns is respiratory and adequate fluid balance, feeding difficulties. They are prone to otitis media and altered dentition. Long-term, altered speech development. All right. And this is just saying post-op and pre-op care before the surgery. Yeah, it's mainly just placing them on their side, just assessing. And we put arm and elbow restraints on them like this because we don't want them picking at the site. And then also frequent burping with them. You don't want too much air going down. All right, that's the main thing with that. Well, thank you so much for coming. You're the last one here. I hope you have a great night.